Okay, as we mentioned here already, we are going to discuss and cover the pharmacodynamic concept. Pharmacodynamic concept, the pharmacodynamic defined as a field of pharmacology that focus on how drugs affect biological system. Normally the drug will interact with a component on the cell surface or like another component inside the cell, and this component we call this structure receptor. The receptor normally is considered like protein, so we need to remember that receptor kind of protein structure located on the cell or inside the cell, and this is responsible for identify the primary target for the drug action. So normally the drug will target the receptor. Most drugs reduce their effect by binding to this receptor. So our drugs bind to the receptor, and by binding to this receptor may activate or may inhibit this receptor. Moving to the interaction now. When the drug interacts with the receptor, the interaction between the drug and the receptor, this will lead to the formation of something called drug-receptor complex, which then trigger biological response. If you look on this algorithm here, when the drug binds to the receptor, this form something called drug-receptor complex. This drug-receptor complex produces the biological effect. Okay, here in this slide here, we discuss the drug-receptor interaction, the concept of pharmacodynamic. As you can see here, the first part on the left side, we have receptor here, and this receptor unoccupied, so there is no action. So when you prescribe medication, when you prescribe this drug here, the drug will bind to the drug binding site on the receptor. So now we have a receptor maybe bound to the agonist, to the medication. This medication, if this medication stimulates the receptor, we call this medication agonist. Now we have another concept. So the drug bind to the receptor, activate the receptor. If the drug able to activate the receptor, this will lead to the activated receptor by agonist, and this reduce the biological response. So it's very important to have it here. When you have receptor bind to the drug, and the drug stimulate the receptor, the result will be biological response. Okay, in this slide here we have present a type of a receptor. What type of receptor do we have? This slide presents four major type of receptor, four families of receptor. The first families, we call the first family ligand-gated ion channel, the first family of receptor. The second family, G protein coupled receptor. The third family, enzyme-linked receptor. And the last family, we have intracellular receptor. This is the major family receptor. We have another minor family receptor is not included in our lecture, but this is a major family receptor we need you to focus on. Ligand-gated ion channel receptor, the first family. The second family, G protein coupled receptor. Third one, enzyme-linked receptor, intracellular receptor. Four family receptor. Okay, start speaking about the first family, ligand-gated ion channel. You can see here most of the receptor located on the cell surface except the intracellular receptor from its name intracellular. That means the receptor totally inside the cell. Okay, speaking about the first type of receptor, ligand-gated ion channels, we have the receptor located on the cell membrane, and we have the location, we have the site when we have the medication, agonist, antagonist bind to this receptor and reduce biological action or reduce action, will open the channel, ion influx, action potential, and lead to the biological response. Okay, the second family, G protein coupled receptor, and you can see the G protein here. You can see the receptor first of all, and this receptor bind to the G protein receptor. This is the G protein receptor, and this G protein consists of alpha, beta, and gamma receptor. So what happened here when the agonist, when the endogenous substance bind to the receptor, this is small circle here. When the drug bind to the receptor, this will activate the receptor and then will activate the G protein. The activation of G protein will lead to the phosphorylation, protein phosphorylation, that produce biological response. the third family receptor, enzyme-linked receptor. As you can see here, we have the receptor located on the cell surface. Here, when this receptor activated by the substance, activate the receptor, this will lead to the phosphorylation, protein phosphorylation, BO4, protein phosphorylation, and this will lead to the intracellular biological response. This is the third family receptor. Family number 4, the fourth family receptor, we have intracellular receptor. As you can see here, the entire receptor located inside the cell. So the medication, the agonist, the drug should cross the membrane and arrive to the receptor. And when the drug crosses the membrane and arrive to the receptor, will bind to the receptor and produce also protein phosphorylation, and the end result will be gene expression. So the end result here is very important to look on the gene expression here regarding the intracellular receptor here. And the end result will be intracellular biological response. So the question here from these 4 family receptor, which of these family receptor associated with open channel ion influx and action potential is ligand-gated ion channel? Which of these 4 family receptor associated with activated G protein? It's like second family G protein coupled receptor. Which of these type of receptor associated with the protein phosphorylation? We have 2 families associated with this process. Okay, start with the first family receptor. We have ligand-gated ion channel. Response to this receptor is very rapid. We need to remember this one. The response for very rapid may last for a few milliseconds. Example for this ligand-gated ion channel, we have nicotinic receptor, we have GABA receptor. So we need to remember example of ligand-gated ion channel. We have nicotinic receptor, we have GABA receptor. So nicotinic receptor and GABA receptor. Regarding the acetylcholine, for example, bind to the nicotinic receptor. So binding acetylcholine to the nicotinic receptor will activate the receptor and cause a skeletal muscle contraction. This one approach is here. So speaking about a nicotinic receptor and acetylcholine action, so normally this is the nicotinic receptor here. If you move to the next slide, you can see here this is a cell membrane. Here we have cell membrane, and this nicotinic receptor located on the cell membrane and consists of alpha 1, alpha 2 subunit, beta, gamma, delta subunit. And you can see here we have ACH. ACH stand for acetylcholine. We have 2 molecules of acetylcholine bind to the nicotinic receptor. When nicotinic receptor activated by binding acetylcholine, this will open a sodium channel, allow sodium to enter the cell, allow sodium to influx inside the cell, and by influxing sodium inside the cell, this will create action potential, depolarization, and skeletal muscle contraction. Okay, nicotinic receptor considered like type of ligand-gated ion channel. As you can see here, when we have acetylcholine ACH, ACTH, 2 molecules of acetylcholine binding to the acetylcholine side on the nicotinic receptor. This will activate the nicotinic receptor and open sodium channel, allow sodium to influx inside the cell, and this will cause the depolarization, action potential, depolarization and action potential, and the result will be skeletal muscle contraction, skeletal muscle contraction. Okay, another type of ligand-gated ion channel, we have GABA receptor. We have three agents may work on GABA receptor. We have GABA as a mediator. Bind to the receptor. We have benzodiazepine as a medication bind to the GABA receptor. We have barbiturate binding to the receptor. So the end result from this activation, activation will be the opening chloride channel Opening chloride channel will lead to the case called hyperpolarization. Hyperpolarization means relaxation of the cells. If this happened on the brain, the result will be hypnosis, induce sleeping, relieve anxiety, and induce skeletal muscle relaxation. Okay, the second family of receptor, we have G protein coupled receptor. As you can see here, this receptor linked to the G protein, and the G protein having three subunit. Alpha subunit bind to guanosine triphosphate. Then we have beta and gamma subunit. So we are talking here about the G protein coupled to the receptor. G protein binding to the receptor. The G protein consists of three subunit. Alpha subunit bind to guanosine triphosphate. Then we have beta and gamma subunit. Binding of appropriate ligand adenine cyclase to extracellular lesion of the receptor G protein. So this one called G protein replaces guanosine diphosphate with the alpha subunit. So what we have there, we have GDB, we have, I will go back, we have GDB receptor will move to the alpha GTB, and this will activate the receptor. Okay, then they try to remind us we have several type of G protein available in the human body. Type of G protein, we have GS protein. S stands for stimulatory effect. So what we have here, stimulation adenine cyclase, GS, and this will lead to the increased level of cyclic AMP. Then we have GI. I stands for inhibitory effect. This will inhibit the action of cyclic AMP and decrease level of cyclic AMP. Then we have GQ. GQ, if you activate GQ, the result will be increased IB3 and DAG and lead to the increased level of calcium. May someone ask, what is IB3? IB3 stands for inositol triphosphate, and DAG stands for diacylglycerol. Okay, let us discuss the details about G protein. As you can see here, the first one, you can see it on the top left side. We have resting state. As you can see here, we have receptor. We have the binding site for the receptor. The receptor here is empty. You can see it here. The receptor is empty. And we have G protein, GDB protein, guanosine diphosphate. That will consist from three subunit, alpha, beta, and gamma, and it's not bind to any component, any receptor or target here. Okay, when you prescribe medication or drug or agonist, when this medication bind to the receptor, you can see the medication, the agonist here. When this agonist bind to the receptor, this will activate the receptor. So what happened here? Activation this receptor will lead to the activate of G protein. And what happened there, the G protein alpha, beta, gamma, the alpha G protein will be separate from the beta and gamma and phosphorylated to the alpha GTB. So you can see here we have phosphorylation of G protein. Number one, we have separation from beta and gamma. So we have alpha GTB. So the alpha GTB now is activated protein. Alpha GTB activated protein will leave the receptor and we move to the third stage. Alpha GTB will leave the receptor and activate the first target. So we have target number one. On the other side, you can see here we have beta and gamma attached to another target, target number two, and lead to another action. So now we're done with the activation. So you can see here, first of all, we have resting state, then we have receptor activation, protein activation. This will lead to the target activation. The target activation here could be effector or could be cells, could be tissues. Okay, then when this operation done and finished, the situation will be recycle, reuse the same. So what happened here? We have dephosphorylation. The alpha GTB will losing phosphate, we're losing the phosphor, and convert from alpha GTB to the alpha GDB and reuse the same cycle. GTB hydrolysis, losing the phosphor and reuse or re-involve in a cycle of this GTB and GDB cycle and with the activation of the receptor. Okay, let us discuss the details about G protein. As you can see here, the first one you can see it on the top left side. We have resting state. As you can see here, we have receptor. We have the binding site for the receptor. The receptor here is empty. You can see it here. The receptor is empty, and we have G protein, GDB protein, guanosine diphosphate. That will consist from three subunit alpha, beta, and gamma, and it's not bind to any component, any receptor or target here. Okay, when you prescribe medication or drug or agonist, when this medication bind to the receptor, you can see the medication, the agonist here. When this agonist bind to the receptor, this will activate the receptor. So what happened here? Activation this receptor will lead to the activate of G protein, and what happened there? The G protein alpha, beta, gamma, the alpha G protein will be separate from the beta and gamma and phosphorylated to the alpha GTB. So you can see here we have phosphorylation of G protein. Number one, we have separation from beta and and gamma. So we have alpha GTB. So the alpha GTB now is activated protein. Alpha GTB activated protein will leave the receptor, and we move to the third stage. Alpha GTB will leave the receptor and activate the first target. So we have target number one. On the other side, you can see here we have beta and gamma attached to another target, target number two, and lead to another action. So now we're done with the activation. So you can see here, first of all, we have resting state, then we have receptor activation, protein activation. This will lead to the target activation. The target activation here could be effector, or could be cells, or could be tissues. Okay, then when this operation done and finished, the situation will be recycle, reuse the same. So what happened here? We have dephosphorylation. The alpha GTB will losing phosphate, will losing the phosphor, and convert from alpha GTB to the alpha GDB and reuse the same cycle. GTB hydrolysis, losing the phosphor and reuse or re-involve in a cycle of this GTB and GDB cycle, and with the activation of the receptor. Speaking about types of G protein, as you see here, we have GS protein stand for stimulatory protein, and GI protein stand for inhibitory protein. Then we have GQ protein. So I will start with GS protein. So when you activate GS protein, this will lead to the activate adenine cyclase, increase cyclic AMP, activate protein kinase. On the other hand, if you activate GI protein, the result will be inhibition of adenine cyclase, inhibition of cyclic AMP, and inhibition of protein kinase A. We have several examples. We are going to discuss it later on. Which medication work on GI protein or which medication work on GS protein. Moving to the another side here, so GQ. So if the receptor activate GQ, this will lead to the activate PLC. PLC stand for phospholipase C, kind of enzyme. Adenine cyclase kind of enzyme. And then we have, after the phospholipase C activated, this will lead to the increased formation of IB3, inositol triphosphate, and deacylglycerol. Inositol triphosphate increase formation of calcium, and with the DSC and calcium, this will lead to the activation of protein kinase C. Okay, in this slide here, we are speaking about the clinical application of G protein. As you can see here, we have GS protein, we have GS protein, and we have GI protein. So we try to maybe apply this to the clinical practice. But first of all, when we activate GS protein, this will lead to the increased activation of adenine cyclase, increased cyclic AMP, and activate protein kinase A. On the other hand, when you activate GI protein, this will lead to the inhibition of adenine cyclase, inhibition of cyclic AMP, and inhibition of protein kinase. Okay, example for some receptor linked to the GS protein. We have beta receptor adrenergic. We have beta receptor adrenergic, number one, followed by dopamine receptor, dopamine 1 receptor, histamine H2 histamine receptor, vasopressin receptor, V2 receptor, glucagon receptor, FSH receptor, LH receptor, luteinizing hormone, ACTH receptor, adrenocorticotropic hormones. Then we have serotonin receptor 4, 5, 6, and 7. So specific type of serotonin receptor work on the GS protein 4, 5, 6, and 7. Serotonin receptor will work on the GS protein. On the other hand, we have some receptor linked to the GI protein. Some receptor linked to the GI protein. We have alpha 2 receptor, alpha adrenergic receptor, alpha 2 receptor. Then we have dopamine D2 receptor, dopamine D2 receptor linked to the GI protein. Also, they said D3 and D4 linked to the GI protein. Muscarinic receptor 2, so we have M2 receptor bind to the GI protein. Opioid receptor bind to the GI protein. We have mu, delta, and GABA receptor related to the opioid. Then we have SST1 and 5. SST stands for somatostatin receptor. Somatostatin is like hormone produced from the hypothalamus and inhibit growth hormone secretion from the pituitary gland. Adenosine A1 receptor, serotonin 1 and serotonin 5 work on GI receptor. CB1 cannabinoids receptor. Then we have melatonin M1 and M2 receptor. So now we have the question: which of the following receptor work on GI protein? Which of the following receptor work on the GS protein? So we have the list of medication: beta receptor, D1 receptor, H2 receptor, V2 receptor, LH, FSH, ACTH, serotonin 4, 5, 6, 7 work on GS receptor. Okay, this slide here presents the GQ protein. The GQ protein bind to the receptor. Here we are going to ask a question. Name the receptor that work on the GQ receptor. So we have list of receptor work: bradykinin receptor, endothelin receptor, cholecystokinin, oxytocin, thyrotropin releasing hormone, gastrin receptor, alpha 1 adrenergic receptor, muscarinic receptor 1, 3, 5, histamine 1 receptor, V1 vasopressin receptor, angiotensin 2 receptor, serotonin 2 receptor, and thromboxane A2 receptor. Okay, this graph here, this diagram present for us, we have the receptor first. First of all, we have the receptor. When the receptor bind to the drug, the receptor will be activated. The activation of the receptor lead to the protein activation. When the protein activated, this will lead to the release of messenger. The releasing of messenger will activate protein kinase. Activating protein kinase will produce biological effect or will stimulate the effector or the tissues or cells. Example for the receptor work on the G protein coupled receptor in general: we have alpha receptor, alpha adrenergic, beta adrenergic, muscarinic receptor, nicotinic receptor, serotonin receptor, dopamine receptor. A drug binding to the receptor, the end result will be complex, drug complex receptor. G protein could be GS, GI, GQ, GO for other. Release of second messenger. The question here: which of the following considered like second messenger? Second messenger, we need to remember the system here: adenine cyclase enzyme, adenine cyclase, phospholipase C, phospholipase A2, and guanylate cyclase. We have for second messenger A's like enzyme, so we need to remember that with the second messenger. We talk about enzyme: adenine cyclase, guanylate cyclase, phospholipase C, phospholipase A2. Moving to the what happened to the effector cells: could be cellular response, could be protein activation, could be gene expression. Okay, we have example here or like application, clinical application for peptide produced from the brain and the heart. and we call this peptide atrial natriuretic peptide, AMP peptide. This hormone or this peptide produced from the heart and the brain, the heart mainly. Okay, this peptide here bind to the receptor, and this receptor called natriuretic peptide receptor, NPRA receptor. So ANB bind to the receptor. So ANB binding to the receptor and lead to the formation of complex, and this will lead to the activation of the receptor, activate the receptor, activate GTP, activate G protein, and the result will be activation of guanylate cyclase, and this will activate protein kinase G. So protein kinase G, and this will lead to the vascular muscle relaxation. So now we have atrial natriuretic peptide. We understand the mechanism. The AMP bind to the ANB receptor and lead to the smooth muscle relaxation, vascular smooth muscle relaxation, the smooth muscles inside the viscers here talk about. Okay, so the first one here, speaking about AMP, atrial natriuretic peptide. What about the second one? We have nitrate or nitrate, and here they bring us an example to the GTN, glyceryl trinitrate or nitroglycerin, and this medication used for patients suffer from angina, okay, or angina pectoris. So nitroglycerin and glycerin trinitrate, this medication work by releasing nitric oxide. So normally the endothelial cells, normal in healthy endothelial cells, the endothelial cells release nitric oxide. The nitric oxide will leave the endothelial cells and enter to the smooth muscle cells. This is the smooth muscle cells, the healthy smooth muscle cells. So we have the neighborhood between the endothelial cells and smooth muscle cells. The endothelial cells release nitric oxide. The nitric oxide will move to the smooth muscle cells, and with the smooth muscle cells will convert guanylate cyclase to the guanylate cyclase activation, and this will lead to the formation of cyclic AMP. So you can see it here what we have, increased formation of cyclic AMP. This will activate protein kinase and cause protein phosphorylation. So when you have activation of protein kinase in the smooth muscles, this will lead to the protein phosphorylation, and this protein kinase will lead to the will act on the myosin light change. So you can see here myosin light change in the smooth muscle will be phosphorylated, but under the effect of protein kinase G, this will lead to the dephosphorylation, removing the phosphor from the myosin light change and lead to relaxation. Okay, this represents the effect of nitroglycerin, for example, here. This medication used for patients suffer from angina. And another medication, you can see it here on this list, I would like to bring it to the attention. We have Viagra here, and this is a brand name for the medication called Sildenafil. So we have Viagra. So what they found here, if we look a little bit, go back, guanosine triphosphate metabolized to the cyclic AMP, and cyclic AMP produce relaxation of smooth muscle, the GMP. However, they found the GMP, cyclic guanosine monophosphate, will be metabolized to the GMP, to the 5-GMP, under the effect of enzyme called phosphodiesterase. You can see it here, BDE. BDE stands for phosphodiesterase. In order to avoid this metabolism pathway, we have Viagra or Sildenafil. Viagra or Sildenafil inhibit phosphodiesterase. This will lead to the accumulation. This will lead to the increased level of cyclic AMP and enhance relaxation. For this reason here we use Viagra for patients suffer from erectile dysfunction. So we use it for the patients suffer from impotence or erectile dysfunction. So you can see here the G protein. We have two medication. One work on the heart, nitroglycerin, and we explain that. Another one work for the patients suffer from erectile dysfunction. We have Viagra or Sildenafil. Okay, again, the Sildenafil here try to explain the mechanism in a clear way. That Sildenafil inhibit the enzyme phosphodiesterase, and they lead to the accumulation, prevent conversion of cyclic AMP to the 5-GMP, accumulate, increase level of cyclic GMP, activate protein kinase, and this will lead to the decreased level of calcium, and the end result will be smooth muscle relaxation, and the end will be erection. Erection in this patient, this one represents the benign atrial smooth muscles. This one here for your information, what type of phosphodiesterase inhibitor do we have? We have Viagra, Levitra, Staxin, Cialis, and Standra. This medication, all these list of medication used for erectile dysfunction. Okay, Alprostadil again, consider like we have Alprostadil, then we have Alprostadil also, how the Alprostadil work. So what we have here, we try to understand Sildenafil work on the G protein, Sildenafil. Nitroglycerin work on the G protein. What else? We have Alprostadil. Alprostadil, another medication for the erection, for endothelial dysfunction, impotence. Alprostadil, type of prostaglandin. Prostaglandin work on the GBCR. GBCR stand for the G protein coupled receptor. G protein coupled receptor here. So stand for G protein coupled receptor. So when the Alprostadil activate G protein, this will activate adenine cyclase, converts ATP to convert ATP to the cyclic AMP, activate protein kinase, decrease calcium, smooth muscle relaxation, and induce erection, increase blood flow to the penis and induce erection. So this another pathway explain the second messenger for adenine cyclase. So messenger here, we have the messenger here, cyclase, then we have ATP as a target. Okay, so we're done with the G protein. We discussed several questions, several cases, several scenario regarding G protein. I will repeat it quickly here. We discussed the angina with the nitroglycerin, work on the nitroglycerin cyclic AMP. We discussed sildenafil by inhibit phosphodiesterase 5. Then we move to the alprostadil, activate the G protein coupled receptor and use for erectile dysfunction. Moving to the third group of medication. Okay, moving to the third group of medication. Here we're still discussing the pharmacodynamic, the receptor concept. We have a type of family of receptor called enzyme-linked receptor. As you can see here, what we have in the slide here, binding of the ligand to the extracellular domain activate or inhibit the cytosolic enzyme activity. So we have the receptor, we have the ligand, we have drug bind to the receptor. This binding to the receptor will activate or inhibit the receptor. Example, we have insulin. We know that insulin is like produced from beta cell, pancreatic cells. Insulin produced from beta pancreatic cells and responsible mainly to regulate blood glucose. And what we have here, they found the insulin bind to the insulin-linked receptor. And when the insulin bind to the receptor, this will lead to the activate protein kinase, and this will lead to the autophosphorylation. Okay, the image here, in this image they show us the inactive insulin receptor. We have insulin receptor consists of two beta subunit, as you can see here, and then we have two alpha subunit, and then we have a sulfide bond, and the inner side we have tyrosine. So we have this receptor here with the component two alpha subunit, two beta subunit. We have tyrosine as amino acid. Then we have sulfide group. Okay, when the insulin bind to this target here, what happened here? So you can see here when the insulin bind to the receptor, this will lead to phosphorylation of the receptor. You can see the phosphor here bind to the tyrosine. And when the tyrosine bind to the receptor, this will activate the receptor and produce biological response. Okay, speaking about the fourth family receptor, we have the receptor located inside the cell. We call this family intracellular receptor. And you can see here the receptor entirely located inside the cell. And therefore the ligand here could be any substances produced from our body, could be epinephrine, could be acetylcholine. Okay, must diffuse into the cells and bind to the receptor. The ligand must be lipid soluble in order to cross the cell membrane and arrive to the target. Example, this epinephrine acetylcholine for ligand in general, but what about the intracellular receptor? The intracellular receptor is different issue. So the ligand could be any substance, but when you speak about intracellular receptor, we have specific type. For example, we have steroid hormones. So for example, we have 6 hormones such as estrogen, we have progesterone, we have testosterone, we have cortisone. All these considered like steroid hormone. So steroid hormone activate ligand-gated receptor, activate ligand-gated receptor, migrate to the nucleus. This will lead to the binding to the DNA sequences, and the end result will be gene expression. So here we're talking about hormones. We're talking about steroid hormones. When you treat patient with hormone due to the hormone deficiency, the hormone treatment effect will take hours, sometimes take days. For example, if the patient suffers from hypothyroidism, so we prescribe T4 thyroxine, levothyroxine to the patient. This will take maybe weeks or months to bring the patient to the normal level of thyroid function or euthyroid. For this reason here, we need to give ourselves time to achieve the balance when you prescribe the hormone therapy to the patient, because this medication requires days and sometimes weeks to achieve balance. Example here is very important, very easy example for us to remember. We have the ovary produce estrogen. The question, the ovary controlled by pituitary, the pituitary produce FSH, follicle stimulating hormone. The FSH will stimulate the ovary to produce estrogen. So you can see the estrogen now as a hormone cross cell membrane, cross the outer cell membrane and enter the cell, arrive to the nucleus. Then we have DNA strand. So you can see estrogen receptor entirely located inside the cells. So pituitary gland stimulate the release FSH. FSH stimulate the ovary, and the ovary release estrogen. The estrogen will enter the cell membrane, arrive to the cytosol, then enter the nucleus, binding to the nuclear receptor, and this will lead to the gene expression. Okay, the same will apply if we can replace this one. For example, you can say, okay, what about the cortisone? The same will be applied here. Apply for cortisone. What about the progestin? The same will be applied. What about the testosterone? The same will be applied. So several medication work with a similar mechanism, work on the nuclear receptor. Okay, speaking about upregulation, downregulation of the receptor, here we are going to maybe cover two main topics for this slide here. We have a case called the receptor upregulation. As you can see here, for the receptor upregulation, with the upregulation may occur when the receptor activated, when the receptor activation is blocked by prolonged period of several days by the antagonist or mean blocker. So when you use beta blocker, for example, you block the receptor. So when we block the receptor, so what happened here as a compensation mechanism, our cells and tissue try to compensate, try to rebuild the receptor. So you can see here when you start using the antagonists, you start using the blockers, so the cells try to build more receptors. You can see here we have limited number of receptors. With the chronic use of beta blockers or like antagonists, the receptor on the cell surface will increase. As you can see, with time, there's an increased number of receptor. We call this aspect like receptor upregulation. What that mean for the clinical application? Does that make sense for us? Is this is important in the clinical practice? Yes. Example for this beta blocker, we have propranolol. We have propranolol. Let me remove the picture here. We have propranolol, considered like beta blockers. Propranolol, if you use it for long term, for example weeks or months of treatment, and what we have here with the beta blocker, we have a more number of receptor on the cell surface. If you decide to switch the patient or stop this medication suddenly, so if you decide to stop this medication suddenly, the situation will be activate all these receptor and cause a case called hypertension, hypertension crisis. So for this reason, we recommend patients to stop this medication gradually to avoid activation of extra receptor and cause hypertensive crisis. Okay, I hope this makes sense from the concept here. So when you prescribe antagonists for long-term period, days, sometimes weeks, sometimes months, the cells, the receptor try to compensate by building more receptor and more receptor. So when you try to stop this medication, stop the medication gradually in order to give some recovery for our system. Okay, if you stop this medication suddenly, the situation will be reactivate all these receptor, may cause hypertensive crisis or angina or myocardial infarction. On the other hand, as you can see here, we have receptor down regulation. They said when you use a long-term reduction, when you use agonist, I will give you another example for the agonist. For example, if you use epinephrine, for example here, or if you use salbutamol, for long term. Salbutamol is like beta 2 agonist. Salbutamol is used for asthma. And another name, salbutamol is like European name. Another name for salbutamol albuterol. It's inhaler for beta 2 for asthma. This is agonist. This stimulates the receptor. So you can see here, when you use agonists, we try to stimulate this receptor. Our body compensation will be decreased number of receptor with a chronic use. So you can see here we have decreased number of receptor, long-term reduction in the receptor number. We call this one downregulation that may occur with continuous exposure to the agonist. So please remember, we have two main concepts. We have receptor upregulation and receptor downregulation. Okay, speaking about the concept of agonist, antagonist. Speak about concept of agonist, antagonist here. Agonist mean the medication bind to the receptor and activate the receptor. Example here, epinephrine, adrenaline. So epinephrine bind to the receptor and activate the receptor. We have alpha receptor and beta receptor. We can call that epinephrine bind to the alpha receptor, bind to the beta receptor, activate these receptors. So for this reason here, agonist bind to the receptor and activate the receptor. We call this one agonist. So when you have epinephrine bind to the receptor, activate, we call the epinephrine like agonist. The same will be applied for acetylcholine. Acetylcholine bind to the receptor and activate the receptor. We have muscarinic receptor, we have nicotinic receptor. So for the acetylcholine bind to the nicotinic receptor, muscarinic receptor, and activate these receptors. So acetylcholine, for this reason, consider like agonists. Okay, on the other hand, we have atropine. Atropine, for example, consider antagonist. And atropine here, block the receptor. Atropine block the muscarinic receptor. So you can see the difference here. Another example, you remember that epinephrine agonist stimulate the receptor. On the other hand, we have propranolol antagonist, block the receptor. What type of receptor? We have beta receptor. So propranolol block beta receptor. So we need to remember which one agonist, which one antagonist. We can go in more detail about, we have partial agonist, then we have full agonist. So we can discuss partial agonist, partial antagonist in more details in separate slide or separate lecture. Okay, another concept here, we talk about selectivity, drug selectivity. Speak about drug selectivity here according to the receptor subtype. For example, atenolol is black beta 1 receptor, which mainly available in the heart and cardiovascular system. On the other hand, atenolol. On the other hand, if you will think about propranolol, black beta 1 and beta 2. In this case, beta 1 in the heart, beta 2 in the lung. This medication is not selective. So propranolol, non-selective beta blocker. On the other hand, atenolol is selective beta blocker. So we need to take this in consideration. And in the practice, we prefer to use selective medication, cardiovascular medication for patients suffering from angina, for example, here. So epinephrine considered like non-selective. Why? Because epinephrine stimulate alpha and stimulate beta receptor. On the other hand, phenylephrine is like selective medication because phenylephrine stimulate alpha 1 receptor. You can see the plus here. So epinephrine non-selective because stimulate alpha 1 and beta. However, on the other hand, phenylephrine considered like selective treatment because epinephrine, you can see it here, epinephrine stimulate alpha 1. The question will apply also on the acetylcholine or acetylcholine. Acetylcholine non-selective again. So we have non-selective for epinephrine, non-selective for acetylcholine. Stimulate nicotinic receptor, muscarinic receptor. What about bilocarbin? Bilocarbin is like belong to the same group. Selective agonists stimulate muscarinic receptor. Okay, competitive versus non-competitive. For example, we have a competition between acetylcholine and atropine on the muscarinic receptor. So we have competition here. What that means for us, the drug with a higher concentration, will displace the drug with a lower concentration. So here we can change the response. If the patient come to the clinic with high doses of atropine or scopolamine, we try to displace atropine and scopolamine by enhanced action of acetylcholine. Okay, moving to the non-competitive irreversible antagonist. Here we have irreversible. The medication mean binding irreversibly to the receptor. The antagonist bind irreversibly to the receptor by bonding covalent bonds and become inactivated. The receptor become inactivated. The example here we have phenoxybenzamine. So phenoxybenzamine bind to the alpha receptor and stay in the receptor and does not remove or displace the receptor. So here we have example for competitive antagonist. When you prescribe atropine to your patient, the atropine bind to the muscarinic receptor. So when you prescribe atropine to your patient, the atropine bind to the muscarinic receptor. In another word, we have acetylcholine in our body. Acetylcholine tried to bind to the muscarinic receptor, acetylcholine. However, when you prescribe atropine, atropine will bind to the receptor and displace and remove acetylcholine from binding. This one competitive receptor here. Okay, so we have competition here. However, if we increase the dose of or enhance activity of acetylcholine, if you enhance activity of acetylcholine, the acetylcholine will bind to the receptor and displace atropine from the receptor. This is a concept of the competitive, and we call this one low mass of action. The drug with higher concentration will display the drug with lower concentration. What happened with the non-competitive irreversible antagonist? So we can see here we have alpha adrenergic receptor, phenoxybenzamine bind to the receptor and prevent epinephrine from binding irreversibly. Even if you increase the dose of epinephrine, you are not able to produce any competition, any displacement. This combination between phenoxybenzamine and the receptor irreversible. Okay. So as you mentioned there, again, this belongs to the low mass of action when you increase level of the higher, when we have high concentration of acetylcholine will displace the atropine. However, if you look on the other side there, for non-competitive irreversible antagonist, even with a higher concentration of epinephrine, we cannot displace phenoxybenzamine because phenoxybenzamine bind non-competitively irreversibly to the receptor. Okay, the next concept in pharmacodynamic, we have functional antagonism. Functional antagonism here, the antagonist work completely on separate receptor initiated effect that opposite effect to the agonist. The practical example here, when the patient suffer from allergy. So when you have patients suffer from allergy, here, and the human body will release histamine. Okay, so a human body will release histamine, and the result of releasing histamine will be bronchoconstriction. Okay, the result will be bronchoconstriction. This is the effect of histamine. So when the patient arrives to the hospital with severe allergy or allergic reactions, we can treat this patient with the epinephrine. So the epinephrine stimulate beta 2 receptor and cause bronchodilation. So you can see it here with the epinephrine, the cause bronchodilation, relaxation of muscles. So epinephrine antagonize the action of histamine. Histamine cause bronchodilation, epinephrine cause the histamine cause bronchoconstriction, and the patient suffer from allergy. On the other hand, epinephrine cause bronchodilation through the different mechanism. Histamine work on H1 receptor, and epinephrine work on the beta 2 receptor, but they have different function. We call this one physiological antagonism or functional antagonism. Okay, the concept here about the therapeutic drug index or therapeutic drug window or therapeutic range. We are going to discuss the median effective dose, the medium toxic dose, lethal dose, medium lethal dose, effective the therapeutic index calculation. The purpose of this calculation here, therapeutic windows or index, to measure the drug safety. So we have we have category for the medication here with the therapeutic window. We have some medication considered like demonstrate narrow therapeutic window. Another group of medication demonstrate large therapeutic window. Example here we have warfarin. Warfarin, oral anticoagulant, considered like narrow therapeutic window. On the other hand, penicillin antimicrobial has a large therapeutic window. Okay, so the drug with a narrow therapeutic window or range require close monitoring because the differences in the therapeutic and toxic dose very small. So any change in the therapeutic dose will introduce the patient to the toxic effect that necessitate the careful monitoring the patient, and we call this one therapeutic drug monitoring. Okay, example for the therapeutic drug monitoring with the narrow therapeutic range. Here we have warfarin, we have digoxin, we have lithium, we have phenytoin. We know that, for example, we have warfarin anticoagulant. We monitor the patient by measuring INR. We have digoxin, narrow therapeutic window. We use it for heart failure, fibrillation. Lithium for bipolar, phenytoin for epilepsy. All these four medication demonstrate a narrow therapeutic window and recommended therapeutic drug monitoring. This diagram here represents the therapeutic index of medication. We have plasma drug concentration here, plasma drug concentration, and we have therapeutic index, another name therapeutic window, we have therapeutic range. As you can see here, the medication, most of the medication need to be in the normal therapeutic range. So most of our medication should be with the normal therapeutic range. And this will be affected by multiple factors. So we need to take this multiple factor in consideration. We have two levels here. We have this level here and above. This level and above. This one considered like toxic effect, maximum safe concentration. There is a risk of toxicity above this level, and below this level here we don't have. We call this one subtherapeutic effect, minimum effectiveness. So for this reason here, we need the medication to be in the therapeutic range, within this range here. This is the effective, this is the window we're looking for, to be in between the maximum and minimum, not above maximum, not below the minimum, because if you have it less than concentration, we have decreased efficacy, subtherapeutic. If you have above the maximum, we have risk of toxicity. Okay, so what we have here, we have a group of medication with a large therapeutic index, large therapeutic window or therapeutic range. We have penicillin, we have ibuprofen, amoxicillin, acetaminophen. What that mean for us? You can prescribe large doses of penicillin to the children without risk of toxicity. You can prescribe large amount of ibuprofen without risk of toxicity, large amount of amoxicillin without risk of toxicity, the same, but we have limit. We have the maximum dose. It's not allowed to maybe bypass the maximum dose of this medication. But for example, if you compare this large therapeutic index, large window here, if you compare with the other medication considered like narrow therapeutic index, you can see the narrow here. So we have a large therapeutic index at the plasma concentration. We have the range to move the patient between up and down for this group of medication: penicillin, ibuprofen, amoxicillin, acetaminophen. On the other hand, if you look on this group of medication, we have narrow therapeutic index, windows or range. List of medication require monitoring: carbamazepine, cyclosporin, digoxin, etosuximide, levothyroxine, phenytoin, brocanamide, thiophanate, warfarin. All these medications require drug monitoring, therapeutic drug monitoring. The reason? Because this medication demonstrate narrow therapeutic index, narrow therapeutic window. So you can see here the narrow therapeutic window mean the maximum effect, the toxic effect is very close to the normal effect. That we have the window is very small compared with a large window. We have large window for other medication. This medication demonstrate narrow therapeutic index and increased risk of toxicity for the patient. Someone may ask about this medication with a narrow therapeutic window. You are going to see patients suffer from epilepsy, for example, and carbamazepine being prescribed for this patient. Cyclosporin considered like immunosuppressant drugs. Digoxin used for the cardiac arrhythmia, heart failure. Etosuximide, anti-seizure drug. Levothyroxine for patients suffer from hypothyroidism. Lithium for bipolar disorder. Then we have phenytoin for epilepsy, brocanamide, antiarrhythmic drugs, thiophanate, this medication we use for asthma mainly, and warfarin as anticoagulant drugs. Okay, this will conclude our session for today. Today we covered the pharmacodynamic. We went through the drug receptor interaction, the drug receptor complex biological effect. Then we discussed the four family receptors, speaking about the ligand-gated ion channel, G protein coupled receptor, enzyme-linked receptor, intracellular receptor, with the example for each medication, each group of medication. Then we move to the example for nicotinic receptor, GABA receptor. Then we discuss with you the G protein coupled receptor, one of the most important family in the pharmacology, pharmacodynamic, G protein coupled receptor. Then we went through the GS protein, GI protein, GQ protein, and then we have G other. And we can remember the cycle for the G protein coupled receptor. And then we discuss, we brought some example for the some receptor work on GS and other receptor work on the GI. Then we brought some receptor work on the GQ receptor. Then we give some practical example for the medication work on the G protein coupled receptor, speaking about the target cells, and we have messenger, and then we have the effector cells. We already covered the nitroglycerin. We spoke about Viagra, Sildenafil, Alprostadil, for example, about the effect on the G protein and cyclic AMP. Then we move to the enzyme-linked receptor. We discussed the insulin, how the insulin activates protein kinase and cause phosphorylation. Then we went through the intracellular receptor, speaking about the receptor entirely inside the cells, and the example there was steroid hormones, and we discussed the effect of estrogen, testosterone, progesterone, cortisone on the gene expression. Then we went through the concept of upregulation, downregulation of the receptor for agonists, antagonists, explain the concept agonist, antagonist, what that mean, and we gave you some example. We gave you some example already. Then we discussed the selectivity of the medication on the receptor. We compare between competitive and non-competitive antagonist. Then we went through the functional antagonism, physiological antagonism, such as histamine and epinephrine. We discussed the therapeutic drug index, therapeutic drug window. We have some medication to consider, like carry the narrow therapeutic window. Other medication has large therapeutic window, with the example and support for that process. Okay, this will conclude our session, our lecture for today. Thank you so much for your watching, and have a great day, everyone.